enhance that, make it better, and give taxpayers a little bit more of a even sort of an even distribution of consideration.
It's a great question. We know from the amounts, the low amount of recoveries, that there are some issues there. And I know, working with both Director Seelig and OMIG, Elizabeth, she's very much in favor of looking at any impediment, and we can work with her and identify those issues for you. In the next few weeks, I'm sure we can come back with some answers.
Thank you. Appreciate that.
Representative Farrar, you're recognized for a question.
Thank you, Mr. Chair. Welcome back, guys.
Thank you.
Seems like y'all here, y'all live here now. I have a question. I asked last time at the meeting about the DRGs. Maybe I just didn't understand. I'd like to know the difference between the APRG or what the regular DRG is in a hospital now. I mean, I know the Medicare system is set up on a DRG for a hospital. Could you explain the difference between the two?
So there are a couple of different DRG methodologies that are out there that are pretty prevalent. The two main ones are the MS-DRG, which is the Medicare Severity Diagnosis Related Group, and the APR-DRG, which is the All Patient Refined Diagnosis Related Group. Medicare does currently use the MS-DRG for their payments to hospitals. Many Medicaid programs have adopted either the MS-DRG or more often the APR-DRG for payments to hospitals. The main difference is that because the MS-DRG was developed for the purpose of Medicare, it is focused on the types of, on both the diagnoses and common severity levels that affect the Medicare population, which is primarily an elderly population. And so when you have a population like the Medicaid population, which is primarily children, the particular sets of diagnoses and acuity levels that are captured in the MS-DRG methodology really don't map well to that children's population. And that's why the APR-DRG is used in those circumstances.
I think that kind of led into my next question, though. So if you set up a Medicaid or APR-DRG system in Arkansas, you wouldn't just plug numbers into the Medicare DRG system we already have. You couldn't just say pneumonia X, then pneumonia for Medicaid Y. That's the system that can't be done.
Right. And because the MS-DRG is on the Medicare side, and what we're talking about is a possibility of developing something like, or the option on the table is that APR-DRG could be potentially adopted on the Medicaid side. Even on Medicaid, they don't have any DRG methodology currently in Arkansas.
But it looks like some states that do have it.
Correct.
How's it working in other states?
It is, it's a hard question to answer. I think generally other states feel like it's working well for them. It's not generally controversial from the provider side of things because it has been developed in a pretty nuanced and sophisticated way to appropriately capture the costs that they will typically bear for those types of diagnoses.
Okay. Mr. Chair, I'd like to have the Stevens Group do a study on this. If we could get to compare the DRG systems that we're using now, the APRG system to the way we're paying hospitals now with our Medicaid population, and just kind of see if there's a savings there, if there's something that would work for us.
Mr. Stephen, do you have thoughts with regard to potentially putting a group together or something on DRG? Is now a good time for you to share that with us?
Yes, Mr. Chair. We, in our recommendations, one of the recommendations is for the task force to vote to create a study group that would study the DRG system that we would facilitate for you. We would have, you'd appoint a few members, and then we would bring the Hospital Association, the Children's Hospital, Arkansas Children's Hospital, and some other hospitals that are interested together with UAMS as well. And then we've already started down that road of coming up with some analysis, but we did not take into consideration some of the supplemental payments here, which are really important. So to get a true amount of what the cost and the savings and the issues and the impact for each hospital would be very important as the next step. So I would definitely think that that's a great recommendation. It is consistent with one of our recommendations.
Well, what I'd like to do is I'd like to make a motion for this committee to consider where we would agree to move forward with that effort, that we would appoint Representative Farrar as the chair from a task force perspective, and then have 4 other members join him from a task force perspective. If Representative Farrar thinks 4 more is too many, you can give me another number in the discussion phase of this motion. And then people that are interested in serving on that along with him, if they would let him know they're interested, and then at our next meeting, we could vote on the full membership of that subcommittee and have a discussion about the rest of the membership. My presumption is we may not have all the members we need, so part of what this motion would involve is Representative Farrar recruiting a couple other folks to be a part of this with him. But the reason I say it like that is I don't want anyone to think that if you are interested, that somehow you're not going to have an opportunity. So the goal is to have enough people to do this work, but also not block anybody out. So in summary, the motion is that we move forward with this study group, that Representative Farrar is the chair, and that people that are interested in being on it with him would talk to him, and that we would have 4 additional folks, a subcommittee of 5. And then in the discussion phase, if that's too large of a group, I'm happy to reduce it. So is there any discussion on that motion? The motion is that we move forward with a DRG study group, which is, from a works process standpoint, led by the Stephen Group in conjunction with many outside groups, that the task force is involved in that, and that the chair of this subcommittee or subgroup is Representative Farrar, and that 4 other task force members will be a part of it. That may be too many, so if we think a smaller number is better, I'm open to that. And then people that would be interested in being on the DRG study group with Representative Farrar could let him know that, so that at our next meeting, we could approve the full subgroup. That would be the motion. We're going to recognize you, Senator Chesterfield, for a question.
Mr. Chair, I'm trying to decide why we're only having, since this is a joint committee of both the House and Senate, why we would not have co-chairs to deal with this issue, or is it an issue that is primarily of interest to the House?
Senator, I'm wide open if you want to make co-chairs for this subgroup. And do you have a suggestion for who you'd want the Senate co-chair to be?
I would leave that to you, Mr. Chair, leave it to your discretion, but I do believe that we need to have that kind of study group that would reflect the, the two-chamber makeup.
Yes, ma'am, I'm totally fine with that. So I would amend the motion that we would have co-chairs, Representative Farrar and a Senate co-chair. And in fact, now that if we do it that way, then we would have 3 other members instead of 4 other members, so that we would have 5 in total. Are there other discussion on the motion? I'm looking for any other discussion on the motion. I don't see any hands up for discussion on the motion. So let me restate the motion as amended. The Stephen Group is leading a GRG study. We're going to have a subgroup from this task force that is going to work in conjunction with them. Representative Farrar will be the House co-chair. We need a Senate co-chair and 3 other members of the subgroup. People that are interested in those roles, please contact Representative Farrar, and at our next meeting, we will complete the staffing of that subgroup. So that is the motion for the committee. Can I get a second? Senator Chesterfield seconds the motion. All in favor? Any opposed? The motion passes. Congratulations, Representative Farrar. You are the House co-chair of the DRG subcommittee group. Representative Ferguson, you're recognized for a question.
Thank you. Thank you, Mr. Chairman. One of the recommendations was to eliminate the independence account that was started. And I guess my question is, when we all wanted that because we wanted some personal responsibility, we wanted people to buy into their health care and to have an appropriate premium, sort of. And I know part of what you recommended was to go to some premiums for these different groups at different amounts. And my question is, do we structure the health savings account incorrectly? Why has it not worked? Because I think the concept we all bought into of having some personal responsibility. And in reality, how would the premiums work any better? Because with Medicaid being an entitlement program and you don't have any, you only have incentives, but no, you can't take them off the program, or there's no recourse if they don't pay the premium or they don't contribute to the health savings account. I'm just trying to figure out how your premium program would work any differently, why our health savings independence accounts have not worked. And if you think the premium program would work, rather than dismantle all this millions of dollars we've spent on the independence account, is there some way to build on that structure with the premium aspect of your program?
I would first say, Senator, that the idea is a really good idea, and it was probably based upon your discussion about personal responsibility at the time. And that's something, by the way, that's in your statute that created this task force, to make sure you have, at least in any solution, the principle of enhanced personal responsibility. I think the most important issue for us was that we felt as a group, looking at the analysis, that I don't think there was a lot of outreach efforts put into the legislation. In fact, there was some discussion, no outreach at all. And you're gonna have these accounts and people don't know, and a lot of them don't know about healthcare and how to use it appropriately, and they don't know about these accounts. At the end of the day, we started to look at the finances and found that the number of activated cards was so low that the PMPM, if you really looked at it, you were paying somewhere in the $50 to $60 range, when the State Employees Association was paying somewhere, same vendor, I believe same vendor, same program, somewhere around $4 or $5. So it's significantly higher than any other, similar account. So with that in mind, then we started to talk about our solutions here to really begin to put more responsibility on carriers. And I know you'll have the carriers here today to testify, and you might want to ask them. But I think that the solution we're trying to raise here is the carriers have a stake in this game. I think they all understand and recognize that. And they could run, they could manage, they could handle that issue at much lower cost and be able to do it effectively, but with the caveat, you are going to need to make sure you have some type of independent auditing so that you've got to make sure they're doing their job. And that's where the dashboard comes in, to make sure you can identify from them routinely, having them come to the oversight committee. This is where we are on our dashboard. We're finding with number of people participating. This is how many haven't paid their premiums. This is how many are potentially in lockup. And also notifying DHS. We recommend on an address issue. If they don't find someone, that they notify DHS immediately. So you're not paying that PMPM. In some states, that's how it happens. So again, it's really kind of shifting the responsibility now to carriers. And let them manage something that they do well on the private market. And so that's really our thinking. And there's about $8 million a year that you're spending on these accounts. And I recognize the vendor did a great job, came to the plate, and we all met with them, and they're really committed, invested in Arkansas. And, I understand that's an issue, but the bottom line is, it's really not working. And I don't think anyone's going to disagree with you there. So that was our solution, and thank you.
So the concept was good, it's just the administration of the program that was
Yes.
poorly run? But you don't think, there's no value in keeping the framework we have, and you think it's better served in the private sector than trying to keep it administered through DHS?
Yes, yeah.
Okay, thank you.
Representative Bentley, you're recognized for a question.
Thank you, Chairman. I know I'm not a member of the task force, but I'm on public health, and I have a couple of quick questions, so that's okay. First, on the $438 million that we're going to save in our general revenue by continuing the private option, can you tell me how much of that is on uncompensated care?
The main uncompensated care component that is included in that figure is it's a projection based on the historical appropriations to UAMS for uncompensated care. I don't have the exact number in front of me, but the projection put it annually at between $30 and $40 million. So over the 5 years that were used to sum up to that 438, it would be approximately $150 million.
Okay, so did you guys study those numbers yourself through UAMS, or did you look at any other hospitals at all on uncompensated care numbers?
So other uncompensated care costs are not, that is to say, the uncompensated care costs just borne by general hospitals are not included in the calculations of the savings to the state funds. But we did look at that separately, and the impact on that, again, I can pick it up in a moment, but I think it was on the order of $1 billion over 5 years from not having a PO. That is $1 billion in additional uncompensated care costs that will just be borne by general hospitals across the state.
Thank you, Chairman. Could I ask a couple other quick questions?
Yes, and the breakout of the uncompensated care that is not included in the $438 million figure is on page 23 of the presentation that they gave last week, if you're interested in looking at that. And yes, you're recognized for follow-up questions.
Thank you, Chairman. One of your recommendations was that we do a real-time eligibility like they do in the state of Florida. Do we know what the cost of that would be?
No, we don't, and one of the things that we would like to do is begin working with the department to get that answer for you. And it can be done, you know, in many different ways. In Florida, the issue, it was not that costly because they already have a very well-run online eligibility system for all programs, all benefit programs. So the question that we would want to be able to find out at this point would be how much it would cost to do it in a way that's integrated within the current EEF system. And I'd like to be able to get back to the task force on that. If the idea is one that the task force agrees with, there's a few ways that you could do it. There are some lower cost ways of doing it, as it would be almost a a non-integrated solution, or you can do it in an integrated solution. But I will tell you that, just on what we looked at in terms of the number of addresses that we saw that potentially are out of state, or when people move and don't notify DHS, and you're paying a PMPM every month, there's millions of dollars in savings, no matter how you do it. And today, you have the ability under the 887 waiver requirements in CMS to file until that money goes away, that funding, to get them to agree at $90-10 to begin to put that type of system together. The longer you wait, the potential is you could have the 90-10 funding opportunity taken away at some point.
I appreciate that. I would like us to know before we move forward, we've spent hundreds of millions of dollars already on eligibility systems that aren't working. So before we spend any more tax dollars and waste them, I'd like to see something, how much is going to be up front.
We recognize that. And
One
also,
last question, if that's okay, Chairman. On the pharmacy package there, we're talking about the numbers where DHS pays a greater amount for medications versus Ambetter or Blue Cross Blue Shield on the private option patients. Could the difference strictly just be that the patients are Medicaid patients, traditional Medicaid, and they're much sicker, more expensive medication? Let's like some update on that. Thanks.
Sure. In the comparison of those two groups, private option groups, 3 carriers versus the state, we took great efforts to try to normalize the claims that we were going to compare to get rid of any biases for difference in drug use in the two groups, or especially to remove super expensive drugs. The reason we did that, in the law of small numbers, some of the private option carriers represented a small number of claims relatively, and if they had several occurrences of very high dollar prescriptions, it would have abnormally skewed our presentation, and we wanted to present average costs. So we took great pains to normalize for drug use and for differences, removing the high cost claims.
I just wanted to come back to one of Representative Bentley's questions about the technology investment for the front-end solution. I too share some concerns about investment, even though I love the concept of being able to do near real-time eligibility so we can crack the code on this global endemic problem that we've got in America and beyond about keeping track of these things. And my understanding from talking to an industry executive that Senator Raper asked me to talk to is that there's actually two different ways to do this, one of which requires Arkansas to spend money building a computer system, the other, which does not require Arkansas to build its own computer system, but rather use the computer power of a third party, in other words, to outsource this. So one could batch these eligibility determinations and send a data set weekly or every 3 days or something of that regard to a third party, have them run this data against a real-time database, report back to the state of Arkansas the eligibility information, and it may be that that solution stands alone for an extended period of time. It may be that as we integrate more programs into the eligibility verification, we actually get a critical mass that it makes sense for us to build our own computer investment. But what I want to make sure that I'm sharing is my newly educated understanding of this recommendation, that it is not like a light switch. Either we spend tens of millions of dollars on a new computer system and get something, or we have nothing but this difficult eligibility verification process. But rather than that, we may be able to make a little, sell a little, and earn our way to the right answer over time. Does that make sense, John?
I think you've laid it out, makes a lot of sense. I'm thinking our recommendations, the batch concept was what we used for matching up currently with the income files. Because today, you're waiting 12 months before you do redeterminations. And we had a conversation with CMS, and they said that it was okay to send that 30-day notice if you find changes of circumstances along the way. So the batch idea on income, we did our own test and found there were a couple thousand that went up beyond that 10% increase within every quarter. So if you're doing a batch every quarter just on income, you're going to save a few $1 million. If you do a batch on the eligibility to start, you're going to save a few $1 million, and it's going to be less costly. No question. The issue on the full integration is, you know, again, we have to look at the cost benefit, and why some states have gone down that road is, again, the federal government's come forward and said that's the ultimate, you know, long-term solution that they'd like. You still have issues here with Curum. We want to make sure that that all works out. So that solution is one of those that we were thinking to come back to the task force with. So, I mean, it's right on in line with what I think that the directors would be looking at.
Thank you very much. Senator Cooper, you're recognized for a question.
Thank you, Mr. Chair. Last time, and again this morning, you mentioned the lockout provision that you talked about first time and you got in your report. And if I remember correctly, you stated that there could be some legal issues with that provision if we go down that road. And that is some concern to me because with the other issue we've just been talking about, I don't want to see us go down a road that's not going to be legally permissible to go down ultimately, and then we try to do something that's not successful. Can you give us some, a little bit more detail on that than you did last time about what's gonna be required to actually, make this happen?
I think that that's a really, again, good question. It goes to the heart of what is probably going to be set up depending upon your recommendations. At the end of the day, I did not say that there were legal issues. What I said was, it may be very unlikely that CMS would approve it. And the issue is not one that is illegal. The issue is the federal government, it's going to be difficult to pass, get that through in a waiver. And here's, Senator Cooper, here's what's going to be the challenge here. There are a number of areas in the box where they have already approved the same lockout provision for the state of Indiana. And your governor and the director, if the task force, let's use the example, were to say, we agree with lockout, your governor and your commissioner, the director, are going to be the ones negotiating that. And when CMS says, we're not accepting lockout, Arkansas, well, what's the reason? Well, we just think it's too harsh, or whatever their reason is. It's not that it's against the law, it's because the federal government will not approve the waiver with that provision. So then it sets up a challenge where, you have to make a decision. And there's a number of these here. So those are issues that we could go over when we start looking at each individual recommendation, strength, and the potential possibilities. But what we tried to give you were ideas that have already been approved in other states. And now going to the uncompensated issue, no question that's an issue. And that's a policy matter that you're going to have to look at and consider. And it could result in additional uncompensated care. And that's just going to happen. We could probably look at potentially what that could be. But the idea is to incentivize folks to want to be able to do the positive behavior type wellness and other areas that you would want to require, which is something that we thought, in talking to other task force members, really important. And how do you incentivize that positive, reinforce that positive behavior? And if you don't have the stick, it is difficult at times to enforce that. And that's really where the issue is.
Well, I'm all about personal behavior, responsibility, but I'm concerned that we don't have the data to prove where we're going and the value of it. Is anybody that's already done that, is there any data out there now?
Yes, there's data from Indiana that we can bring to you in the next.
How long have they been on it?
It's been a few years now, at least 2 years, more than 2.
And
But we've talked to them already about the HIP program and other areas. We could definitely get that information, whatever they have.
I appreciate it. You do that. Thank you, Mr. Chair.
Thank you, Senator. And again, just building on Senator Cooper's question, I just want to make sure that I know personally, work requirement, for example, is something that I absolutely would love to see. And given that CMS and the administration has said, we're not granting that to anybody, we're not going to grant it to Arkansas, the way you guys have handled that in your recommendation is you said, Arkansas is not walking away from any of the things we'd like to see in the new program. But what we're going to do is, according to your recommendation, ask for everything we can possibly get from the folks that are there today, while simultaneously designing a waiver that will request everything we'd like to have, including, for example, a mandatory work requirement, in the hope that the new administration, whomever it is, will then grant what we want for the long term. Is that correct, John?
Yes, if that's what the will of the task force, you can do a hybrid, and that's kind of what we said. But at the end of the day, there are going to be a number of issues that you all decide. Lockout's one of them. Another one could be premiums. If you don't do your wellness program, you're going to pay maximum premium. CMS may come back and say, we're not going to accept that. So there's a number of those issues that once you get to negotiation, but Representative Collins' premise is what we try to do is to give you the in the box where CMS has said yes in the past, or where they have the authority to say yes, so that it can be
an Arkansas solution. And then you're gonna set up a discussion and a negotiation, just like any other state. And then you have the option, if you go along or they go along with that clause that allows you to back out with proper transitional notice, to go to another alternative, which you could have, which is something that we had mentioned out of the box. Could be something that you come up with that's totally different. So yes, Representative Collins.
Thank you. Representative Boyd, you're recognized for a question.
Good morning. Thank you, Mr. Chair. So, some prescription drug questions here. So, one of the recommendations that sounded good, because one of the things you stated in your report is, generally speaking, a prescription drug is a pretty low-cost intervention to help with overall health care. Is that correct?
Yes.
Okay, so keeping that in mind, right now there are prescription limits on traditional Medicaid, but they're not on private option patients. So with traditional Medicaid, you start with 3 prescriptions a month, you can go up to 6. But in the overall real world of healthcare, that creates a lot of burdens for providers, whether that be for patients, and you have to deal with extension of benefits and so on and so forth. So one of the recommendations you have, which to me sounds like a good recommendation, is actually to remove the limits on maintenance medications. So let's just say you get 6 slots a month, but if you were on metformin and glipizide. So my question is, have you thought about what is a first step if we started with multi-source generic maintenance medications, rather than just going whole hog and saying, hey, let's let them have their Januvia and their Latuda and these other maintenance meds. Have you thought about that as an approach, or does that make sense?
Makes sense. We did not put any effort into constructing the maintenance drug list or to modifying the claim limits per person per month for people who are not on maintenance medications, because those things could go hand in hand. We could go, if you took out maintenance medications, it may make sense to decrease the available slots for acute medications. So there were a lot of intertwined issues that we didn't tackle with specific recommendations. As to creating the maintenance list, I think you could do a cross-section of cost and maintenance drug to arrive at the drugs that really don't need to apply to the limit at all, because they don't add substantial cost incrementally by themselves.
Okay, thank you. Mr. Chair, I've got another question. Do you want me to ask it, or?
You are recognized, Representative Boyd, for your other question.
Okay, thank you. So back just to Mary Bentley's question, it was very similar to one that I had asked last time. And so I just want to, this is a confusing issue. I mean, you and I work around prescriptions, and we've seen how all the billing and stuff works real time, and the formulas, and we have a good understanding of that. So one of the things that I concerned wasn't taken into account when you say the average retail claim for a brand name drug is $300 for DHS and $200 for the private option, is if Medicaid gets rebates from things, and so there might be a situation where they're rebated more from the brand name than the generic. So I'm just telling you, real life Arkansas, Adderall XR, Focalin XR, there are limited generics available, but if I go buy them, they cost less and I'm reimbursed less. So knowing that there's a formulary that actually mandates that you use the brand name drug rather than the generic ones that are available, would that not drive up the brand name prescription claim? And does that take into account the fact that dollars are rebated back that then lowers the net effect to the state budget?
2 questions. I'll take them in reverse order. The rebates that come back to the state or to the private option plans based on their formulary, we did not take those into account in the comparison of the underlying drug costs. We looked at ingredient cost and dispensing fee as defined as the underlying drug costs. Too difficult, with rebates appearing in arrears, sometimes 150 days, 180 days, 200 days after the occurrence of the claim. It was too difficult to come back and compare rebates to the actual claim that generated the rebate. So we left rebate analysis out. But you're absolutely right. The difference in underlying cost is mitigated by the collection of rebates. Problem is it's mitigated on both sides. And to answer your first question, we do understand that here in Arkansas, there are absolutely really good decisions to use an expensive brand medication because the net cost after rebate collection is below that of a generic with its smaller rebate collection. And so we understand that phenomena. It probably is a marginal impact in the overall comparison of underlying costs.
So it's probably a marginal impact, but you can't say for sure that.
Can't quantify it, no.
Okay, thank you.
Representative Meeks, you recognize for a question. Thank you, Mr. Chair. And my question is surrounding the Human Development Center, or at least the first set of questions, everything. I understand that you did the recommendations, and then Mr. Kellogg got a chance to tour the Conway Human Development Center. And so I was wondering, based upon that, and now that you had a little time to kind of think about it, are there any changes to any recommendations? Do you have anything that you would like to add further based on it? Because I got some feedback from folks who were very concerned that this was a one-sided recommendation as far as HCCs. I know you said, let's form a commission, let's look at them, but that a lot of the things like in the appendix, I guess, and everything, they were afraid that you were only looking at what the Disability Rights of Arkansas group was saying, and it wasn't kind of a more balanced approach. So you could kind of address that, and if you were change any recommendations based on that visit.
I'm going to defer to Richard because he made the visit, but I want to say I had a call with Senator Rayford because he had raised the issue as well, and I want the committee to know that the overriding issue for us was in looking at the HDC in the last report that the state had done on the buildings, the cost it would take to refurbish some of the buildings was a major issue, and it didn't seem like there was a lot of, there were motions or some folks were trying to put some money into refurbishing some of the buildings, but the cost was enormous for the whole state. And these folks are folks that need, some 24/7 care, and so the quality now became an issue. We need to look at the quality. Unfortunately, we didn't get a chance to see all of the facilities. We saw the Conway facility, and Richard can talk about his experience. And what we thought originally, we never once said there was any issue on quality because we didn't hear that. And so it was actually verified that quality was not an issue. But what we did see was there wasn't an investment, an upgrade in a lot of those facilities. And the question in our mind was, there was also no comprehensive look at the future, Representative Meeks, of those facilities and what they need if they're going to stay, upgraded and continue to provide that quality. We do feel that there might be some individuals in some of the facilities that want to go to the community if you move into the rebalancing into the community and not into the HDC centers. But that's their choice. So we're going to be meeting with the families today. A representative from the family contacted us. Richard has some additional research that can tell you what we did. I think it's important that recommendation be seen by the committee as one that looks at this in a comprehensive manner to really put together, for the first time we've seen in Arkansas, a comprehensive report on what is needed and if this legislative body is going to commit tax dollars to refurbish those facilities versus is there one or two that you may want a longer term or shorter term begin to downsize. If not, then you need to make the decision to take care of those people that are in those facilities with good quality. And that's something that we just didn't think was being looked at. And that, we definitely want to look at this further. Richard?
Oh, thank you. First, I want to say that all of our recommendations involving developmental disability people and families is based on the fact that the location of care is an individual state decision. So you will note that the overall recommendations There was no recommendation to close any facilities, and nor did we project any savings from rebalancing the developmental disabilities, because we recognize the importance of this issue to the people of Arkansas. We also, so that is definitely something that permeates our overall recommendation that led to what John was talking about, factors that we did look at. We looked at the overall cost in the June 16th report on the building, and the total is $183 million. It's substantial. We looked at the balance of community resources for waivers and for HDCs. That's a fair comparison. We recognize that Arkansas has invested a lot of money in people with developmental disabilities under 21, but the national comparative data that we had in our report is in relationship to home and community-based waivers and ICFIDs. So that's where the national data came from. There's no question that the national approach in most states is towards community-based services. We didn't go down the road of making that as the only recommendation to pursue in the future. There's no question that there's been a lot of litigation. I read the decision that in the case you had here that you prevailed on, and frankly, I thought that was the right decision. It should be an individual state decision. I did visit the Conway facility with Representative Meeks. We invited other people from the family groups that were unable to make it. It was a rather quick visit. We had talked about going to all 5 of them at the beginning of this project, but the 4 months went by like a rocket. I can say unequivocally, based on my experience with HTCs in many states, in many roles, that the Conway facility is about one of the best I've seen in the United States, and that includes the Northern Virginia Training Center in northeastern Virginia, that way back when was considered to be the best in the nation by the Department of Justice after they left the facility. We got them out of there. So I was very impressed with the staffing. I was very impressed with the resources that were available to the people who live there. I was very impressed with the specificity of the programming down to durable medical equipment and the personalization of that equipment on the campus. I was very impressed with the few residents that I spoke with, and I was very impressed with looking at the very seriously challenged people and the fact that they were being attended to on an eye-to-eye basis by the staff that I observed. So I appreciated the opportunity to visit there. And we think, as John said, that you have another factor was a lot of states have strategic plans. And we thought we would find a strategic plan that included capital costs for existing facilities, future facilities if we decided to build one, or savings if we decided to close them. We didn't see them. So we didn't see a plan like that. So that's where the idea of the commission came from. And I do recognize that the appendix information is pretty much what's going on out there and across the country. You know that. So the idea of the commission was for Arkansas to take the opportunity to see where you want to go from where you stand.
Now, if I can just finish with that, Representative Meeks, and to talk about amending the recommendation, we would be very amenable to whatever this task force decides. And I think the intent is, again, for a commission to be formed and really do a comprehensive analysis of what's needed to continue the quality, because that report in June of 2015 really concerned us, because there was a lot of deterioration and other issues that we saw in that report from an independent agency here.
I mean, yeah, if they've got additional data with the human development centers, and everything, any further recommendations, I would love to see that and have that where we can actually take a look at and start that discussion. Can I do another question? This is going to shift gears as far as solutions are concerned, because one of my biggest concerns that I have with private option is that we are at a silver level benefit package. And I would like to see, if we're going to go forward with us and we're going to do this through some kind of business or whatever, to have more flexibility in the plans that we offer, whether it is able to do some kind of catastrophic coverage that has a set amount of doctor visits per year. I think it's standard in some of the catastrophic plans. Also the potential to allow people to go into the Medishare type plans, you know, if they feel that they want to go in that direction. Those might be more efficient, more cost savings, rather than to say you have to go with an insurance plan through an insurance company. And I don't know what the possibility if the federal government would even be open to that, but those are, you know, some of the suggestions that I have heard from folks to, you know, again, try to get cost containment, but also to be able to provide folks with health insurance that they might need.
I think in answering that, Representative Meeks, the out-of-the-box idea that we have recommended could absolutely bode well with regard to your point. You could do, Representative Hammer mentioned concierge care. There's a movement around the country to do more concierge. You could do a lot more with your county systems. You could be creative in amending those, or limiting the EHBs, if you call it, capping them. There's a number of options. But from everything we've seen, it's not going to be approved by this administration. And so it doesn't make a lot of sense for us to give you those recommendations and say, that's where you should move right now, because they're going to say no. And then the option becomes, you've got to make a decision. Do you want to continue or not? And we've given you all the data and the finances. What we thought we would do is, we really thought about this. You could do something right now, which is a pre-ACA 1115 waiver, which does not accept the ACA. And so you could do what you're talking about, possibly negotiate a waiver, but you have to be out of the ACA, and you'd have to probably, they would require you to go back to your normal 30% match. So I believe we did factor that in, and it's going to cost a lot more. So you raise really valid points. And the question, there's a lot of states thinking about what the questions that you raised, thinking about it. We're trying to be practical. These are the issues that you're dealing with today, and you want to, you know, do you want to continue coverage for those individuals? And can you continue with meeting all those parameters that you set forth in the task force legislation? Personal responsibility, transparency, all the issues that we saw. And so I think you can do that, and I would recommend that you also make sure in the waiver you negotiate, like Representative Collins was saying, an opt-out clause, so that you can do some of the things that you want to do with the next administration. Again, depending upon if that's where your legislative body wants to go.
Thank you, Mr. Chair. Thank you. We're going to skip down to Senator Rayford. He had a question on the Conway Development Center. Senator Rayford, you're excellent. Recognized.
Thank you. I appreciate it. I'm also excellent, Mr. Chairman. I appreciate the opportunity to jump in here, and I thank you for the call that you gave me. And I wanted to make sure I jumped in here with Representative Meeks, because you did say that perhaps some amendment to the language should be had. And I just want to make some points based on what you said. Since I've been in this legislature, every single session, several of us have tried our best to address the Human Development Centers. I'm looking at Dr. Seeley, he knows this. It has been the responsibility of our DDS to have a comprehensive plan. I was told at different times over the several years that there was a comprehensive plan. We had a session here, I guess it was the last session or session before, where the Senate had actually committed that we were going to put funding to the HDCs in our state. And the governor at that time, Governor Beebe, had said he had no problem with us putting the funding there to help that situation. It was the other body in this legislature that stopped us from progression on being able to get that done. So I want to make sure that members understand here that as we look at this reform, it troubles me that we continue to kick the can down the road on this particular issue. It also troubles me that there are 2,900 people on the waiting list. I feel like that waiting list should not be there, and I also feel like that we should take care of the HDC issues. Well, we're actually discussing how to make coverage available that's subsidized for able-bodied people. I have a real problem with the fact that we have people that cannot speak, cannot lift their head, cannot talk to you, cannot communicate with you, but they are living. And we have given them a quality of life here in our HDCs, and I appreciate your kind words. But I wanted to say that for whatever reason, we know what needs to be done as it relates to the HDCs, and we know what needs to be done as it relates to the people that are on the waiting list. But for whatever reason, we continue to adopt other programs and put money in other projects in this state and never take care of that issue. And so I want this body, and especially this task force, to be mindful of whatever recommendations that we make. I feel that we're at a point where it is a moral obligation that we address this and not continue just to pay lip service to this issue. And so, Mr. Stephen, I would recommend that, based on our conversation, that you do address the things that Representative Meeks has brought up and I brought up to you. And I want to put on record as well, Mr. Chairman, I'll say, I guess I made more of a statement than I have anything based upon the context. But Disability Rights of Arkansas has done a real good job of dividing the disability community, and that's not been helpful. And actually, you will see them bring accusation against our HDCs. This is a group that is federally funded, and they bring lawsuits against the state of Arkansas. I find it very troubling that an organization who has been given a prominent role simply to bring lawsuits against our state has been given a voice regarding policy in our state. If they want to work to find solutions, fine, but I have a real problem with them being given any kind of deference, frankly, when they have been the number one cause of a lot of lawsuits, in many cases have been dismissed in our state. So I would appreciate you making sure that. The other thing is that I keep hearing about what's going on across the nation. I take objection to that, because the state of Vermont, for instance, I have heard them say to me personally that they are going to have to look again at what they have done, because they have found they're spending more money to have an individual cared for individually 24 hours a day than they were when somebody could be in a good quality facility where there is a nurse in charge that can care for several of them at the same time. So I know that once they were going to push everybody out into the communities, and some of them, if it was my child, I would definitely want my child at home. But for the families that cannot have somebody at home with them, DHDC is the only option for them, in my opinion. And so I would like to know from you, Mr. Kellogg, do you acknowledge that there are some states that actually have now taken a second look at this because they are spending more than they were with the facilities?
Yes, and thank you for asking me that. I think states across the country, across all their disabilities, are constantly looking at what their prior policies resulted in relationship to outcomes and cost. And cost drives a lot of this. I was there in Vermont in the 70s when Vermont moved towards community-based programming for people with developmental disabilities. And for many years, the cost of that actually did work to the state's benefit, which was why it was originally passed by the elected officials in the state of Vermont. As we mentioned in the report, there were 14 other states, some of them quite large, that have also closed all of their state institutions for people with developmental and intellectual disabilities. As I stated, we believe this is a state decision. I applaud, Senator, personally and professionally, your commitment to a balanced approach. And I believe that that's the best way for states to proceed. The cost factor is important. Vermont's cost, if you look at the healthcare system in Vermont today, is substantially more expensive compared to other states for a variety of reasons. But that's really not the point. The point is that states should make the decisions of where people with intellectual and developmental disabilities should have their lives in a safe, qualitative, protected environment.
If I can add to, Senator, I think it's paramount, though, that there be a very comprehensive review. If you feel that the department has done this in the past, I'd like to see that, because we just could not find a real good, comprehensive analysis of what is needed to continue that great quality care for the families and for the individuals. And it may be $183 million. And it could be done over a number of years with bonding or whatever it is. It could mean that that commission decides, you know what, one of those facilities is just too much to keep going, and we need to look at potentially downsizing. And where do the families stand, and how do they get involved, and transitions for every single individual matters. And I was in a state too where I've seen down, the transition, but we involve the families. And so a lot of those issues have to be decided, and unfortunately, we as a group did not get the sense that that has happened. And so I think it's important if we amend this recommendation to amend it. I don't want to leave with our group, our issue is having the legislature and the families and the stakeholders and the community all involved and come up with recommendations that you could pass off to the legislature that have meaning and meet some of these issues, which may involve the community-based solution. But it also may involve what you've been trying to fight for, which you so eloquently have stated. Because these people in those facilities and the families deserve to have that type of solution.
And John, I agree with much of what you said. You have spoken into an issue that has been a very sensitive topic for many years before you got here. And so my last comment on this, so that we can move on, is the fact that I guess what I'm saying here today is that I'm disappointed and very frustrated that I have been given information to say that we have a plan many times, but the plan never gets executed. And my personal opinion is that we've had enough reports and enough discussion. Let's just do what we know that needs to be done. And that is put our money where our mouth is. When we say that we care for these individuals and that we want to see something done, then let's do that. And so with that, Mr. Chairman, I appreciate you letting me speak on the topic, and we will definitely be addressing it. And hopefully we will see some resolution.
You're welcome, Senator. So here's what we're going to do. We've got about 25 minutes until we're going to break for lunch. We've still got lots of questions. I'm comfortable if we come back, if we still have more questions after lunch, if you folks, go back to the end of the table. But if we do wrap the questions up before lunch, then we'd be able to go to E on our agenda, and that's E of up through N. So you can count on your fingers how many more agenda items we have for today. Senator Ervin, you're recognized for a question.
Thank you. One of the things in the report, in the findings, is I'm very concerned about, and this kind of goes back to the discussion about the per member per month premium and what do we get for that. Really concerned that your data showed that there was not an appropriate use, that 38% of the private option members had not had a claim for a visit to a physician in the entire year. And that seems, in an entire year, for 38% of those folks not to have seen a doctor is alarming to me. So, and then it kind of ties in with the overutilization of the emergency room department. And so my question is, what is the responsibility for the carriers who are providing that? Are they just paying claims and providing that benefit of paying claims, or is there more that we should have built into that premium that we should be expecting? Because that, and the discussion needs to be, because at one time this legislature had a debate about navigators, and those were folks hired to really navigate people towards the federal exchange and the subsidy portion of this, and not necessarily for this population. So I think that's a discussion, that's kind of getting mixed up there. So one of the things, I'm just really concerned about is that they're not seeing a physician, they're not seeing a primary care physician, and we're paying these premiums for an entire year without really much of thing to show for that as far as their costs, their medical costs are concerned. So how can that be restructured to where there is a point of entry? And I look at when they enroll, how they enroll in a private option, when they enroll. It seems very clear to me that if you wanted to use the system more efficiently, better utilize the system, that you would go to a primary care physician and then sign up from that point on. That guarantees that first visit would be with the primary care physician. Is there any ways that we can restructure even just the enrollment process? And would then that eliminate the out-of-state addresses and things like that, if they actually showed up in person for this program? That's my first question.
I think it's a great question, and these are the types of questions that you need to be considering. We thought, and I think Representative Ferguson and others had the same question, and some have started to say, well, maybe you decide not to pay the PMPM until they show up at primary care. So you really want to incentivize primary care, that's an option. But that becomes administratively difficult, and we were just thinking as a group, because we didn't consider that, now you're going to ask the carriers to get involved, and they're not going to get paid until someone goes to a PCP, and how would that work? Having them, or you can have DHS do it, and until you get a primary care visit, now the carrier begins to get involved, and it's just a lot of legwork, and it just seemed a little administratively difficult. So we thought maybe what we should do is require, again, more responsibility on the individual. The insurance agents are here, they're going to testify, they're on the agenda. I think they are definitely willing to do a lot more. I think you need to make the decision on health disparity through education and being able to do some work in the community. You could change that paradigm and dynamic, I believe, with a little effort. And you also have the carriers that are here, and I would ask them the question, are you willing to do more for that PMPM that we pay you to help us to ensure that we get good primary care and follow-up? And we also recommended on the medically frail that you go in a different route, and that these individuals be required, if they come in with an assessment and it's identified by a physician that they're frail, then they would go and be on the medically frail program, which means they have to get in to see the physician, because you want those individuals, if they're frail, to immediately see the physician and go and follow the physician's direction. So there's a lot of recommendations that we have given you that I think address your issues, which are great issues.
And one of the things that you had mentioned in the previous meeting was on the assessments. I'm very familiar with the disability determination at Department of the Social Security Administration and how that procedure occurs. Is there not value in looking at how those are assessed with physicians on staff? And then what can we learn from that where we wouldn't have to necessarily reinvent the wheel and pay, one of the things that concerns me is like the healthcare independence accounts. It was partly my idea, but a good idea. A lot of us supported that, but then it gets administered so poorly. But can we look at that process to see how we can replicate that? Because you had mentioned it, and I thought that was a good thought. And what the barriers would be, perhaps, within that system, because I know those assessments are done by physicians on staff there.
Yes, I'm making a note. That's something we would have to look into. It's a good point, but I would tell you that I would first want to look at the 3 or 4 states that have physician required on medically frail visit and recommendation before they actually become medically frail. And I'd like to know how they're running their program, which might not be that costly. And the disability determination process takes so long, and it may be an issue there too, administratively. But again, it's a great question, Senator, and I'll have some information for you.
And my last question is, and because you also look at your claims, and your claims data was a lot of them were under $50, and that's interesting to me because that seems like that would be more of a primary care visit versus an emergency room visit, or is there anything? That was the question. And then the claims data, when you listed on page 35, the ICD-9 codes, there seems to be so much information that can be gleaned from the claims data that we already are processing through HP. Is there any recommendations to put queries and types of reports that could be additional reports that we could tailor education, or we can tailor more appropriate usage of the system based on their individual health, that providers are already providing this massive level of detail? And it just seems like it's just flying out the window and we're not doing anything to really capture that. So do you have like recommendations on systems and reports that HP could provide for that level of detail to really help us customize for this population?
First, on your question about the high number of low-dollar claims by individual, since this is a relatively healthy population, that's actually not unusual in that on the private insurance side. It's pretty typical for fully half of a privately insured population to have almost no healthcare costs in any given year, and then of course it escalates up quickly. So that in and of itself is pretty common for this kind of population.
And the other thing I'd like to address as far as the information from MMIS, HP, this is a really important point here that you've raised. I know that UAMS is putting out or has put out information on population health, and we recommended that you all look at really, as a legislative oversight, making sure the department and the carriers are actually putting out data on population health within metrics within the program. I think we shared some examples that other states do. I think this is a really important point. It goes to value. Other states' legislative bodies, I have seen on a quarterly basis, have a common dashboard that they will review with the department on MMIS based on claims, almost as real time as you can get.
Correct.
But they're watching the trends. They're seeing that immunizations are down. They're seeing that diabetes prevention's down. And they're asking questions of the department. Why is this? What's happening? And you should do the same with the carriers. And that's just something we didn't see that's happening here. And I believe the carriers will be very willing to do that, working with you, and so will the department. But they're going to need possibly some resources out of their MMIS shop to develop those types of reports. I think they have enough dollars in their own contracting right now that they could just shift priorities and get you the best dashboards in the United States.
Okay.
But I mean, that's something that's going to be really important for you all, I think.
And, well, in my perspective, it's about communication. It's about relationships and communication. And if you're able to see that immunizations are down or diabetes, you can communicate that in a marketing campaign from the state. We have the ability to do that. We're just not effectively doing it to address these populations. And I feel like there's a lot of layers there of being able to get those words out and get that information out to just the consumer. I mean, Walmart does a great job, and everybody shows up on Black Market, Black Friday on the day after Thanksgiving. No reason in the world why we couldn't build in this widget and create that kind of communication standpoint of just communicating, but driving that communication, that marketing effort by data is so important to me, but also giving the providers the ability to create that prescription for their life. And other agencies, like we discussed, or you have brought up with our university system.
Again, I think your department has done a really good job in a very complex area on data in terms of obtaining improvement in a short period of time. They have individuals that are competent in terms of data that can meet your vision. I really believe that.
I appreciate it. Thank you.
Senator Chesterfield, okay, we're going to go to, who's in seat 22, Phil? Senator Elliott, you're recognized for a question.
Thank you, Mr. Chair. Mr. Stevens, It appears to me that many times, whether it's your recommendations or anybody else's, and two examples come to mind of what recommendations we're considering, for instance, is freeze out. And one of the things that we've done that you have let us know has not worked, and therefore not recommended again, is to have savings accounts. So it just appears to me that many times as policymakers, we will put something in place through the, and I don't mean this in a pejorative way, through the privileged eyes of all of us without thinking about how it's going to fall onto the folks who have to actually carry it out. And I think the health savings account might be one of those. But we tend to think carrots and sticks and incentives are going to be received by everybody else the way we would react. So I'm just wondering two things. And regarding your recommendation about education. For each one of these recommendations, could you help us, or would you recommend that we look at these through the prism of an entire culture of this state, not just from our eyes? And secondly, in other states, have they done any of that kind of work, either through educating themselves or educating the folks who have to actually be a part of what we think is going to be great, to make sure that they know how to carry it out and not just come to this without presuppositions that everybody's going to respond the same way we might. If you could respond to that, I appreciate it.
I think it's a really good question. There are states that have moved into the expansion, able-bodied population by and large have done a lot of outreach and education to especially areas that you're talking about that have either health disparities or language barriers or other issues. Because, again, you're dealing with a population that really never experienced the type of health care that everybody else has that's not in that socioeconomic status. So there needs to be some type of education. And that will go a long way, I think, especially from our meetings in the communities that we went to, hearing from individuals that, didn't recognize the fact that, use the first of all, as primary care, didn't recognize the fact that, this system of care is out there. There's a behavioral health benefit now that's involved, and there's other issues. So, I think you have to look at it from both prisms. That's what we're trying to say here. I think, but you have resources in the community today. We've recognized one of them is going to be testifying, the independent agents. They meet with a lot of individuals on a one-to-one basis in the communities, representing the carriers. You have the carriers that are sending an information packet out in the mail to the community, to the members, and what is going on with the follow-up there. And that's an opportunity. And there's a number of points where there already exists opportunity. And you have the primary care physicians that we've talked to in the community, we believe are very much willing to be a real significant player as well. So, you got to be able to coordinate that. And we are suggesting in a lot of our recommendations, if you kind of look at it from the carrier's perspective, I think they could do a lot more proactively to meet some of those needs that we're hearing about. Richard, I know you were with me in the community, so you have some additional thoughts.
Well, thank you, John. I would just add on what other states have done. States have looked at outreach type. Let's use outreach as a general term. Outreach education. What's your benefits? What's expected of you? Who do you call for assistance? This is the list of your providers in your community. This is a navigator type program. I'm sure you've all heard of that. I'll say that as a generic kind of model. How you implement it in your program, whether you do managed care, fee-for-service, or private option, I think is a next question. But as a navigator, what's the length of time for navigator services? Is it annual and then it stops? What do you expect the beneficiary in response to education outreach, such as a navigator? The community worker program, which you piloted here in the state, has gotten national attention. You can use another model. That's another model. We've met recently with some of the MCOs in Louisiana and Mississippi that are actually hiring people in local communities at the county level in the Delta to go out and talk to their neighbors about how to access their healthcare services and what it means if they are in fact a Medicaid beneficiary. So there are a couple of different models that you can look at. They don't have to be oriented towards increasing volume, but they should be oriented towards a person knowing what their benefit is, what's expected of them, and how do they get the assistance they need, and if they have a question, who they call can actually answer their question at the community level, not just at the point level.
And I appreciate your response from the standpoint of the folks out there who are the consumers as well. But I also think, I guess, Mr. Chair, this is just my quick little summation of this. I also think it's really important for us as legislators to, when we think we have a brilliant idea, and it likely is, as well as thinking about the folks who are the consumers, or a way for us to think about before we just put something in place. Take, for example, the freeze out. And you can tell me if I'm thinking fallaciously here. That sounds like something that would scare me to death, and I would react in a particular kind of way. And so I automatically assume that when people hear that, they're going to go, oh, I'm going to get in here and do the right thing. And I think that's fallacious just from the standpoint of we just assume everybody's going to react the way we do, and we could do something like that. If we don't think about this carefully, we do something like that and end up with more uncompensated care than we ever thought about having. So the overall point for me is let's look at it in terms of consumers, but let's examine ourselves too before we put things in place to be sure we know what we're doing. And I'm hoping there are other states, who have done that kind of thing, think about it much more carefully when they put it in place, and we have data to say it worked because they looked at it carefully and did the kind of underpinning things they needed to do to make a brilliant idea reach fruition and to do something good. Thank you, Mr. Chair.
Okay, so it's 11:30, so what we're going to do is we're going to break for lunch till 1 o'clock, then John, if you and your team could come back. What we've currently got in the queue, Senator Chesterfield, Representative Hammer, Representative Gray, Representative Ferguson, and Representative Servillo. That'll be the order that we pick up with, and I'm hoping that we can finish the questions for your group in that first half hour, maybe 45 minutes, so we can move to Director Seelig and the next items on the agenda. So thank you very much, everybody. We'll see you at 1 o'clock.
Can I talk to you before you get out of here? I'll let you go.